Hi Pete, what is nonvalvular atrial fibrillation?
That is an excellent question, Nita. Thank you for asking. So atrial fibrillation, or AF, is a type of irregular heart rhythm, and nonvalvular atrial fibrillation is a type of AF. You might have seen this term in the product literature for the direct oral anticoagulants, or DOACs, as the SPCs advise that all of these drugs can only be used in nonvalvular AF. But it's actually taken a long time for any consensus to be reached on what this term actually means. Each trial used slightly different definitions of it, so this makes it difficult for clinicians to know whether a DOAC is appropriate for the patient in front of them. And this leads to some patients being excluded from DOACs inappropriately. Earlier this week, myself and Nita found a patient who was inappropriately denied a DOAC years ago, so it's important we learn more about this. But first, let's recap why atrial fibrillation increases someone's stroke risk. So when the heart's in the steady, pleasing beat of sinus rhythm, the blood's pumped smoothly through it in a happy little conga line. In the erratic, unappealing rhythm of atrial fibrillation, the blood can't form a conga line, so it struggles to travel through the heart, creating pools of static blood in key areas. The static blood starts to stick together, forming clots, and the worst outcome of this happens when a clot travels out of the heart up to the brain, causing a stroke. This means we can define AF as a prothrombotic state. So when we start to talk about valvular AF, we're looking for any conditions which would independently increase the thrombosis risk over and above what we'd expect to see with AF. Interestingly, this risk isn't actually increased by most valvular problems. So under the current definition of valvular AF, there's only two conditions to look out for, which are moderate to severe mitral stenosis and mechanical heart valves. So let's find out why. So for mechanical heart valves, clot risk is increased by loads of different factors, like hemolysis from blood cells getting squashed by the valve's mechanism, erratic blood flow through the valve, and the contact pathway, which is triggered by the blood detecting artificial materials nearby. For mitral stenosis, though, we need to delve a bit deeper to see why this increases the clot risk. In AF, the majority of clots form in this small finger-like projection off the left atria here. This is called the atrial appendage. As with other parts of our anatomy, this can come in a variety of shapes and sizes. And whilst this does have an impact on clot risk, we don't have any guidance on this in general practice. So this is a problem for the cardiologists. In mitral stenosis, the valve exiting the left atrium doesn't open properly, meaning the heart has to do a lot more work to push blood through. This leads to an increased pooling of blood in this critical area for clot formation, increasing the risk of thrombosis. This risk is compounded over time because the left atrium starts to expand to compensate for the added force needed to pump blood through. This can lead the atrium to become massively swollen, and the large volume of static blood there can form huge thrombi. The largest recorded weighed around 500 grams. To make matters even more confusing, mitral stenosis even increases the risk of clot formation elsewhere in the heart, with a significantly higher portion of patients developing clots out with the atrial appendage. So it's not surprising that the companies organising trials for the DOACs excluded these patients. In other conditions, like mitral regurgitation, the issue is backwash between the chambers of the heart. So because the blood isn't staying still, this doesn't increase the clot risk. Also, with aortic valve problems, the issue is with blood leaving the ventricles, so there's nothing about either aortic stenosis or regurgitation which would increase pooling in the atrial appendage. So we can actually use DOACs for patients with all these conditions based on current guidance. So that's where we're at right now with the DOACs evidence-wise. But what's next? There's an interest globally in exploring these conditions further because properly preventing clots in these patients can save lives and reduce the risk of disability from strokes. There's been trials already looking at using DOACs both in mechanical heart valves and mitral stenosis. Whilst these unfortunately hadn't had enough positive results to change our practice, as protocols get refined, I do see these drugs eventually being used for these conditions. The other technology in this area is also changing, with new surgically implanted devices like the Watchman, which physically blocks off the atrial appendage to prevent clots. These treatments are promising, but the evidence is not as strong for them as it is for anticoagulation. So for the time being, the DOACs are the best treatment we have to prevent strokes in AF, and this is the best definition we have to tell which patients we should use them for. See you next time.